Hi, everyone. Dr. Michael Miyazaki again, bringing you another episode that I'm really excited about. This is, I think, a critical part because oftentimes in our Vista Apex Solutions YouTubes, we do talk about endo. And when you get down to the endo, doing your root canal and you're about to seal it up or obturate it, you just never know if those canals are as clean as you want them to be. And we all know that you could have done everything perfect, but there's a lot of bacteria down there. It's not going to heal up well. So today we have Dr. Randy Cross who's with us, and I think this is going to be really something you want to listen to. So Dr. Cross practiced for 10 years as a general dentist and has been an endodontist for the last 4 years, and today practices in Santa Cruz, California. So if nothing else, you want to go visit him in Santa Cruz. But anyway, Dr. Cross, very nice to have you here.
Oh, it's thrilled to be here, Dr. Maisaki. So really cool to be talking endo and talking about Vista Apex. So I'm glad you had me on here talking about my little domain here. So that's great.
Your little domain is going to be great. So let's talk about well, the topic of this is going to be what we call the indicator. And
Mhm.
so, in your words, how would you describe the indicator to a colleague?
Yeah, so the indicator is a way to check to make sure your root canal is clean. So, we finished our routine, we finished irrigating, we use whatever activation method, and we never really know if it's clean or not. Do we know, should we make the canal size bigger? Did we miss a canal? Did we use a strong enough irrigant? So, what this device does is it checks to make sure your root canal is clean. So, I think it pairs well with endodontics because we have a CBCT to find the number of canals. We have apex locators when we're at the end of the canals. We have great sealer products to make sure we close it off well. But a big question mark has always been, did we clean it up enough? So that's what the indicator does. It kind of solves that problem that's been in root canals is it actually clean enough to fill? And now we actually have a quantitative way of knowing is it clean or not.
Yeah, no, I think that's great. So before we go into the backstory, and that's what we were talking about before we started this recording, is that I really want to get the backstory from you. But just so the backstory makes sense, can you tell us how the indicator works? So you've done your root canal procedure, you've shaped it, you've irrigated it, and now you're before you get to obturation step, real briefly, what is the indicator? What do we have to do to use the indicator?
Okay, so the indicator, how you get a sample and how you check
Yeah.
it is you rinse away. So you think you're done, you're ready to go. You give a quick rinse with water. So you get a milliliter water with a 27 or 30 gauge syringe, and you just give it a good rinse to rinse away all of the disinfectants in the canal. If you try to sample straight sodium hypochlorite, it doesn't work too well. So you have to rinse that away, get the water. Once you rinse away the disinfectants, you go ahead and you aspirate a sample out of each of the canals. A question get asked, right, can I do each canal or do I do all of them? I just do them all at once just to make it easy. And I just basically aspirate out a little bit of that water. So now you have about half a drop worth of water in your syringe. And as opposed to just throwing it in the trash and closing up the root canal, with the indicator, what you do is you squirt it in the little test tube. So you can see right here, you go ahead and give a little squirt in your syringe. And then you go ahead and you get that sample, you squeeze it down, and you go ahead and now shake it and load it in our device to get a reading. So basically, again, real quick, you rinse away the disinfectants, you aspirate out a little bit of the saline, you squirt it in the test tube, you shake the test tube, and you put it in the indicator.
Cool. And then you get a reading, and you know if that reading's within a reasonable level so that you can go and obturate it. And if that reading's really high, then we know we have to go back in and either irrigate more, instrument more, or whatever we have to do to get it cleaned out. So cool. So no, thanks for giving us the backstory. So now when we go in, well, now for the explanation, now when we go into the backstory, I think the backstory is going to make more sense. So hopefully everybody kind of has an idea of how this works. All right, so let's go to the backstory. Like, when did this idea start to brew in your brain? And how did it come to fruition to this point?
Yeah, so it started during residency. So it was the first semester, it was finals week. I'm like supposed to be concentrating on, the tests and all the midterms and everything like that. And I was, or the finals and everything like that. But I couldn't get over the fact there's not a way to see if the root canal is clean. And then during clinic, you'd have these professors walk by and say, you'd ask, can I close it up in one visit? They'd say, well, is it clean enough? And especially this one Professor Dr. Schechter, even Dr. Rojas and Dr. Swag, my mentors, but they would always be like, "Is it clean enough to fill?" And everybody like, "Yeah, it's clean enough. It looks clean," and it was just completely qualitative. Just because a canal looks clean doesn't mean anything. And I kept on kind of just thinking, well, there's got to be a way to see if it's clean. And we used to culture bacteria to see if there's still living bacteria in the root canal. And the problem with that is great information that's 2 weeks too late. So, but we can't, it's very difficult to actually culture anaerobic bacteria. And it's just that's not the way to do it. And then if you can't culture bacteria, does it really matter? So I kept going back, there's got to be an easier way. And the easiest way and the most accurate way is to check for ATP. ATP is adenosine triphosphate. It's a biomarker present in all cells on planet Earth. Everybody in dental school has learned the Krebs cycle and learned the amount of ATP that you get from a glucose. And because it's in every cell on planet Earth, it's just a good indirect measure of is there still stuff in the canal. So during my finals, I just couldn't stop thinking about it. And I finally convinced my wife to let me, buy
Yeah.
these chemistry equipment to go measure for it. And it shocked me because when I started looking inside the root canals, there's a lot of ATP. And as you start the root canal, it's very high numbers and it goes down and down and down until you're at where you think you're ready to fill. But the thing is, when you think you're ready to fill, some of these numbers are high, some of them are good, and some of them like there's almost no ATP in there. And I think there's real value in knowing which ones you think you're done at, but there's still some more gunk in there. There's still some more ATP, and which ones are just completely clean. You can close it up. There's nothing else you can do inside that tooth to clean it. So it just gives you a little bit of other extra information. So again, it was during residency, I couldn't stop thinking about it. And sure enough, when I looked into it, no one had really explored ATP in a root canal in this sort of fashion. And it just works really well. A quick, rapid 5-second test for us to find out if it's clean or not.
We don't have to wait days to culture it. We know pretty fast right then and there.
Yeah.
It's cool.
Yeah, days to culture and information that doesn't give you much value because you
Yeah.
can't culture most of the bacteria growing in the root canal anyway. So what's the point of trying to culture it if you're only culturing a subset of the bacteria as opposed to this, which everything has ATP, everything. So
Yeah. No, that's very cool. So now you have this idea. How did it get to, I guess, the commercial aspect? How did that evolve?
So then from there, we went ahead and I got connected with a couple of comrade colleagues, and one of them, Dr. Nagesh Bola, a friend of a friend, just took it and ran with it. So a lot of the problem was, well, there's ATP, but what does it mean? So he did 1,000 patient study where he looked at the average ATP scores before rotary, after irrigation, and after activation, and even in some cases, if you had high numbers, if you did the round of activation. So with Vista Apex Help, we took all those numbers and divided up into 1 to 100. So when you get a score of 70 out of 100 on your Endocator test, that's not a 70% failure rate. That just means that it's higher than the average patient in this study from Dr. Nagesh Bola. When you get a score of 10 out of 100, that's not a 10% failure rate. It's a score of 10 out of 100. So if you think you're ready to fill and you get these high scores of ATP, thanks to his study, we can now kind of put in our heads, okay, it means there's more ATP, or the score of 5 out of 100 is pretty clean. We're probably ready to go. So that's a big part of where that numbers came from for the indicator scale.
No, that's cool to hear that. I mean, it's research based. So now, as a clinician, we're again doing the root canal, and I test it. Does it fit in the workflow really easy? Is not much change?
Yeah, and that's the best part is it's a 5-second test. You can get these you find out if it's clean or not. And the good part about the workflow is um, if it's high, it's not like we don't know what to do to clean it. So if
Hmm.
it's a really high score, you may want to think of, well, let me get another round of activation. Let me use my laser another time. Let me use my endo activator or endo ultra. Whatever activation technique you have, and or even a big one is, and there's been lots of research to show that hypochlorite doesn't work instantly. Triton doesn't work instantly. It takes a little bit of time. So a lot of times for me, if I get a high score, I just walk into the next room. I do the exam that's been waiting there for 5 minutes for me, and they're probably happy to see me. And then I go back and obturate. So it kind of pairs well, and it gives you a lot more confidence on those one visit cases, to just close it up and know it's clean and know that you did everything you possibly can on the inside to clean that root canal.
Yeah, no, that's cool. So, have you noticed, like, I guess in a clinical situation, if that score is high, have you noticed that it's more likely not to heal as well? I mean, is it something you've actually observed? Just
So
one.
I've had a couple come back and fail. And so the cool thing is there's not like one reason why it's high. So and I some people do it on necrotic cases or and I kind of do it on most everything. So I've had ones where I'm about ready to finish. I have a C-shaped canal. I get a high score, and I'm like, it shouldn't be this high. I've done everything right. I've done everything the same thing I did the last couple times, but this one's still dirty. So this C-shaped canal had a missed canal in there. So I was able
Mhm.
to find that missed canal. Pretty similar example is on a mid-mesial. I thought I was ready to close it up. I got a high endo score. What's going on? It was because I had a canal in between the mesial buccal, mesolingual, the mid-mesial. So that was a pretty cool example. And I've had cases where I just couldn't get the number low. I couldn't get it low. I closed it up, ended up being a vertical root fracture. I've had another one where I did my device to get it read. I did my normal routine. I got the sample. My device was in the car at the time. I'm like, well, just it's okay. Like one case out of my whatever it is, I didn't test. It'll be fine. Sure enough, I look at the numbers and it's sky high, and it was a retreat case, and I end up coming back 2 weeks later and failing. So is it? It would be great to get some studies to show what these numbers actually mean as terms of success. And the other thing is, if it's a high score, it doesn't mean it's kind of fail 80% of the time. It just means you should it suggests you may want to clean it up a little bit more before you close it. So
Mhm.
yeah, I've had individual examples of high scores being bad. I've had lots of great examples where low scores are good. And I've
Mhm.
also had examples where low scores and the person had post-op pain. And it's like, do I give them antibiotics? Do I not? In the back of my mind, I'm like, well, there's nothing in there. I may have extruded some hypo. I may have, given the PDL injection, may still
Mhm.
cause a little ache on that tooth. But I don't really have to be too worried about bacteria because I've done everything we possibly can inside that tooth. So it does give me lots of good information and lots of individual. But again, I'd love to get some more research out there and have it not just be me talking about it or Dr. Bola talking about it, but everybody talking about, man, this works well for me, or this solution works better, and just kind of fill in some of those questions.
Hmm. Yeah, because I guess if we seal it and the number's high, I mean, there's a greater chance, like you're saying, it doesn't mean it's going to fail, but there's a greater chance that it's not going to heal up as well because we have a lot of bacteria still in there. And I
Yeah.
think,
And,
no,
and,
go ahead.
and or even like I like to do MTA fills sometimes, and then I just
Hmm.
cut off the apex. So if I have a question, I'm just gonna fill it with MTA and just cut it off. Because I mean, I like doing it because it's great, but it's easier to just cut off the end of the root, or at least lets you prepare for it too, and which ones to
Yeah,
recall. So
yeah, no, and then when you think about it, that if for some reason that endodont endodontically treated tooth doesn't heal, I mean, it's pretty costly both, whether the GP or the endodontist. One, you've got to explain to the patient that, hey, we have to do something else because it's not healing up after they spent maybe an hour and a half or 2 hours in the chair having the root canal done, and now you have to retreat it or do something else. So they're not too happy about that. And then just from a time perspective, because we've been talking to a lot of clinicians, and when you do a retreat, as far as the GPs, when they do a retreat, a lot of times they don't charge the patient again for that same service. So, then it could be another hour and a half or 2 hours to retreat that because it's usually harder to retreat. So the cost starts to add up. And when you think about using the Endocator, it's relatively inexpensive compared to the endodontic procedure. I don't know, the cost is somewhere about the cost of doing probably a molar root canal in most practices. And then the little test reagent tubes aren't that expensive either. So it seems like it's really would be beneficial to incorporate this into probably every endodontic procedure. Or would you do it more for your molars, or what would you say?
for me, I think that the big ones are the necrotic cases because
Okay.
this one is not like because the pros and cons of ATP, it's just present everything. So blood, nerve tissue. So I do it in vital cases and had the examples earlier where I found the mid-mesial or
Hmm.
missed canal in the C-shaped canal. But clearly, if you're doing a necrotic case and you're getting high scores from ATP from bacteria, so I recommend doing it for all necrotic cases. But I mean, especially some cases like if you have a tooth with a 3 unit bridge on it, and then you or your general practitioner is going to go ahead and cement that bridge the next visit, you got to make sure that's really, really clean because no one's happy about getting a hole drilled through their bridge. So in those cases, it really makes sense to check it, make sure it's spotlessly clean. It's not going to be an issue, and then that we can kind of be a little bit more. You'd be much more sure that it's going to work out because you've done everything you possibly can.
Yeah, no, cool. So yeah, just so everyone's listening, high readings could be more than you didn't clean the canals out. You could have totally missed the canal and the ATP's high. There could be a vertical fracture somewhere where, there's something leaking back into the canal after you've cleaned it out. So that could be a high reading. So yeah, it's just a good indicator that if you're having a hard time getting those numbers low, maybe look at
Everything.
something
So
else. Yeah.
even your a missing wall, if saliva is going in, it's going to show you. If you have like apical fluid coming out the end, it's going to tell you that. If you have bacteria in the canal, it's going to tell you that. So it's for better or worse, it shows you everything. It doesn't
Yeah.
really know like, oh, this is a gram positive bacteria. This one's okay, is gram negative. It doesn't tell you that. It tells you, is it clean, is it dirty, and then you
Mhm.
need to figure out what you need to do to get the score you want.
Yeah, no, that's cool. I think the nice thing about the way you're explaining it is just you're talking about the strengths and the limitations, and I think it's always important when you're using a piece of equipment to know the limitations so that you're not frustrating yourself if you can't get that score down to zero. So no, I really like the way you explain that. So let's switch gears now. We've explained what the indicator is. I think that's good so that when you're doing this part of the discussion, people know what we're talking about. So we went through what the indicator was briefly. We talked about how it was developed. We talked about how it's used and what the indications mean. So now the next part, I think, is if you're training me to use it, how would you do that? Because we want to go for success. And I think it's fairly easy to use, but you're probably the one clinician throughout the entire world that's used it the most. And so if you're teaching me how to use indicator, how does that work?
So, the first one you do is you turn it on. So,
Okay.
you get a device, you turn it on, and again, I would recommend everybody just sample, 10 teeth. Don't really think too hard about the scores. Just get a baseline. And the reason is you might be a little different. So, say for example, if you stay 2 millimeters below the apex and and you're two visit guy, you're going to get really low scores. If you're like me, I like to really clean it up. I'm a 2506 to the apex. So I might get a little bit higher scores and I'm okay with that. But the first thing you do is you turn on your unit and then you go ahead and you get your root canal. You think you're ready to go. You give it a good rinse with your water. So you get your saline with your syringe. You go and you rinse out the tooth with your saline, get rid of all those disinfectants. Well, now you think you're ready to close it up. So you go ahead and you take a sample from inside that tooth. So again, you think you're ready, you go and get your sample, you aspirate the sample out with your little syringe, and you squirt it in the test tube. And at this point, you have your sample in the test tube. You push down on the test tube to get your sample to the end of the test tube, and you shake it. There's an enzyme in the bottom called luciferase. It's going to be lighting up. The ATP causes this enzyme to get bright. It's very efficient. You and I can't see it because it's so dim, but this Endocator device can. So we're going to go check and see how sterile my tap water is. And believe it or not, it should be a relatively low score. In 5 seconds, we get a score of 0. So that's a good score. So again, on another case, it may not be that simple. So again, we get the disinfectants, we rinse it away. We use our 30 gauge syringe, kind of activate the walls and just kind of get a good sample from the sides. You aspirate out that sample. This one's gonna be a little bit dirty. I'm not sure if people listening can hear, just saw that, but I licked the side of the test tube. So again, if that was a root canal, we wouldn't want to close that up because that would be dirty. So we go ahead and check the second sample, hit retest. And again, this is a 5 second test. So before I'm even done drying out the canals, I can see if it's clean or not. This got a score of 91. So again, these two teeth would have looked the exact same to you and I, but this indicator test can tell. The other kind of things I like to do for this test is when I give it a rinse with 1 milliliter water, I like that. I like to rinse everything away. I think that we're so careful about the disinfectants that we kind of let it soak in there and don't really rinse it away. So a final rinse of milliliter water is a good thing. Personally, I like to put my water in the freezer. The reason being is that there's been studies that shows less post-op pain if you cool down the tooth at the very end. I also put a little triple antibiotic paste in there because, if you're going, the last thing to touch the tooth is little antibiotics. That's okay with me. And then I inject it, then I aspirate it out, inject it in the tube. And again, it's a 5-second test, but in that time I'm getting the results, I'm using my paper point to dry out the apex. If I see there's blood in the paper point and I get a high score, well, that's unfortunate. I'd rather not have bleeding be an issue, but I manage the bleeding. I'm probably not, I may or may not be able to get a good result for that case because there's bleeding issues and or if there's apical extrusion. If I see the paper point is wet from the apex, I know I got a high score. The part that's weird is when you get a high score and you don't know what it is, it's like, well, man, what's going on? So those ones I find is just another round of disinfection, another activation, works really well to lower that score until it gets to the point where I'm ready for that to close it up. The other benefit too is I think the patients love to hear, ma'am, this root canal went great. I know the first one didn't work, but our retreat went fantastic. We confirmed the canal. We found a missed canal. We confirmed it was clean with our ATP Endocator test. There's nothing else we can do we need to do to this tooth. We're going to close it up for you today, ma'am. So they just love to hear like what you're actually doing and get, I think they definitely appreciate some quantitative feedback of, what's going on as opposed to I cleaned it really well. You can now give them an actual score. So twice today I had a score of 1, I had a score of 2, I had a score of 20. But just the patients like to hear we cleaned it up. And then if it's not clean, you can go clean it up a little bit more.
Yeah, and I think that's great. So let's go back because that was cool. It's so easy to do. Let me ask some questions. If I leave irrigant in the canal, whether it be sodium hypochlorite, ETA, chlorhexidine, and I test it, what do you mean it's not going to be accurate? Is it going to be like zeroed out because there's still irrigant in there,
It de-
or?
it depends. Yeah. So the EDTA and chlorhexidine I mean, you probably wouldn't want to leave those in there. But the sodium hypochlorite, it does a great job of dissolving like biofilm and tissue and things like that. It also does a good job of degrading the enzyme. So the enzyme would get attacked too. So that's why I say you don't really want to, you don't want to sample straight up hypochlorite because it's going to give you low to wonky number. The
Mhm.
EDTA is kind of funny. If you do that right before you test, you could actually get the numbers up a little higher. And the reason is EDTA is a great job of removing the smear layer and like uh, and cleaning inside the tooth. So I've noticed if I sample the hypochlorite does a great job of lowering those scores. If I do EDTA or chlorhexidine is kind of net neutral. It sometimes will bring up the score or not do much. So I know certain situations like open apex, you may want to change how you treat things, but definitely the high strength sodium hypochlorite is the best way I found to get those numbers down. Or Triton works really well too.
Okay, that's cool. And then, when you have rinsed out that irrigant and you go in and take your sample of your sterile saline that's in that canal, your sterile irrigant, you had mentioned half a drop to a drop. So is just a half a drop to a drop, that's enough that to react with the reagent to give you a good reading?
Yeah, you can do more if you want to, but and I leave when I rinse out with the saline, the sterile or sterile water, um, I leave the chamber somewhat flooded. And the reason for that is it's just easier it's such a low volume.
Hmm.
Um, if it's a broken down tooth and it's a single root, there's not that much volume in there. So if it's a molar, I leave the chamber flooded. If it's just like a really tiny root and it's a single rooted tooth, I actually would leave a drop of water. Like I wouldn't squirt everything out when I'm using the distilled water to rinse out the tooth. And the reason is some of it's going to get caught in dead space in your syringe. So if you dilute the sample, it doesn't do much. It'll still give you relatively the exact same score. So if I know there's gonna be a case there's not that much volume of water, I'll actually just leave a drop or two in here, and that way it's a little easier to eject out the sample. After a couple cases, you'll realize, man, if I just put it in the canal itself and I'm just sampling from the coronal part of the canal, I mean that's not that much volume, and a lot of it will just get caught in the syringe. So to make up for that, I sometimes leave a little bit in the syringe itself.
Okay. Yeah, that's what I was going to ask, if the volume of your sample size affected the scores, but it doesn't really then.
Yeah, it's only like if you can't squirt it out that it affects it. But the
Hmm.
way around that is if I know it's a case where I'm not going to have that big of a sample, I just go ahead and I leave a little bit of water in the syringe.
And then a tip that you gave, just the irrigant in the freezer. So the irrigants, they don't freeze or anything like that. You just keep the syringes in there?
Yeah, and like I think technically, if you want, if you're, and again, I use this as a tool. I use
Yeah.
this to. I'm not necessarily in a study situation where I'm trying to get the most accurate numbers. If you put the water in there cooler, it could actually affect the enzymes. If you're really overloaded with like 3 milliliters of water, that's freezing cold, it may actually change your results slightly to be lower because the lower the temperature could affect the enzyme. But for me, I want my root canals to work and I want them to be less post-op pain. And so recently I've been inspired to just put the samples in the freezer right before we're ready to give a rinse. That last little rinse with water, because it's so cold, will lower the temperature of the tooth, and the studies have shown there's less post-op pain
Hmm.
by cryotherapy. So I've been trying to do that and seeing if it works. And so far, it seems patients are having a little bit less post-op pain. So it seems to be working for me. So again, it's another thing you can do. And especially if you're already getting rinsed with water anyways, just
Yeah.
to something nice for the patient.
Yeah. No, that's cool. No, you covered a lot in a short amount of time. Really, really appreciate it. Are there any other anything else that you think that's important to share with the viewers?
I think I mean, this isn't like a secret, I think if you're looking for research, looking for a great project, I mean, this is a quantitative, easy test that, it's a very inexpensive test. It's not a $100,000 laser or
Hmm.
gentle wave. It's cost of a molar root canal to guarantee the ones you've been doing work. The cost of a file you can check to see if it actually works. So, for research, it's great. It's a 5-second tool. You can line up. I'd love to get more research out there. But yeah, anything else? And then my email is drcross at wattsendo.com or ddscross at gmail.com. Feel free to reach out in case you want to get involved and kind of get the word out. So,
Yeah, no, thank you very much. So, now this is exciting just because it's something new, and we've done endodontics just assuming that if we go through the process that the canals are clean, and we all know that endo is not 100% yet, and this is just another tool to help us get there. We have a saying in occlusion that if you can't measure it, it's more opinion. Our opinion is, I think I got the canals clean, but if you can measure it, then it's fact, right? So if I have gone through the procedure and I still have a score of 100 and I sealed up and it fails to heal, then I could have said I thought it was clean, but that's just my opinion, right? But the fact was it was still really dirty. There was a lot of ATP in there. And if I get it down closer to zero, there's a better chance it's going to heal, provided everything else is going well. And it's fact. So if you ask me how clean did you get that canal, and I can measure it, and I can say, well, it was at 100 when I sealed it up, or is it zero when I sealed it up? It means something totally different than just saying I think it was clean. So I think this is
well,
really cool.
Well, the other thing is kind of cool if you have like a growth mindset too. And
Yeah.
like it's like when I started, I get high scores and it was didn't dent my ego because I didn't know what they meant. But like as you get dialed in, your scores go down and down and down and down. You know what to do to get it clean. So it's
Yeah.
not just like these individual teeth will be variations. Like that's good and that's important too. But also use a clinician, you get like every case you get feedback on how you did and what you could do better and what worked out. So it's kind of cool. Like a lot of these like cool. I love lasers. I have a laser. I think it's very neat. But it's not like you buy a laser and all of a sudden everything's a score hero. You still have
Yeah.
to use it. And Dr. Justin Kolnick is a big advocate of, you got to make sure you use it and get the laser in there and get it disinfected. And his protocols that he's figured out has got very low scores for him. Same with me. My scores have gone down. So just in general, just great feedback for any dentist to really get dialed in the root canals to know are they actually cleaning the tooth enough to seal it up.
Yeah. And I think that's a great way to end it. Well, Dr. Cross, thank you very much for your time. Thank you very much for explaining how you came up with this. Thank you for coming up with this, the indicator. And I know a lot of the viewers are watching this really will be excited to try it out. And hopefully it just changes the world of endo because now we finally know what it is that's in that canal, besides a microscope, because like Dr. Gilbert said, you can't see clean, right? So even with that magnification, we really don't know how clean those canals are. But now with the indicator, at least we have a way to measure that. And I think it's going to be a great tool for all of us to use. So thank you very much for developing it.
Well, thanks for having me and taking the time to interview me, and also Vista Apex for helping to get this idea out there and all the various steps it takes to get an idea through patent, through research, through design, and to the market. So, thank you so much for having me on here.
Yeah, no, thanks. Yeah, and if any of you have any good ideas, Vista Apex Solutions has a really open R&D team like Dr. Cross is talking about. So if you have a good idea and you need help developing it, come over to Vista Apex and we'd be glad to talk to you. But thank you very much. A great interview.
Thank you, Michael. Bye.
Good night. Hey, that was a great interview with Dr. Cross. And if you like that information, please hit the like button. And if you want to make sure you don't miss out on more of these great interviews, hit subscribe. We're trying to create this community of like-minded colleagues trying to do the very best for the patients. See you at the next episode. Thank you very much.